I want to thank the meeting organizers for having me to this conference and giving me the opportunity to present. My name is Anthony Mato. I'm the director of the CLL program at Memorial Sloan Kettering Cancer Center. And today I'll be presenting the optimal selection of new molecules in the treatment of chronic lymphocytic leukemia with a focus on frontline and relapse refractory disease. These are my disclosures. And while we'll be focusing today on recent advances in the field in terms of treatment, of course, I want to emphasize that the most important decision that anyone can make when caring for a patient with CLL is determining whether or not therapy is warranted in the first place. There are excellent guidelines available from the IWCLL to help guide when a treatment decision is warranted. And of course, once that decision is made, there are certain tests that need to be performed in order to help select the best therapy for a patient. These include a history and physical examination, as well as performing a molecular genetic profile, which includes FISH analysis for deletion 17p, conventional karyotyping for complex karyotype, next-gen sequencing for a TP53 mutation, as well as IGHV mutational status. Let's delve into the clinical trials, and I'd like to start by focusing on a classic study, which is the Cll8 Trial, which is a randomized trial that was published in 2010, looking at the comparison of FCR, fludarabine, cyclophosphamide, rituximab versus FC. And of course, this trial was overwhelmingly positive for FCR over FC in terms of progression-free survival. But I want to highlight the curves and emphasize a few things. To begin with, there's no obvious tail on the PFS curve for all comers. And outcomes are extremely poor with FCR in patients with a deletion 17p or a TP53 mutation. And so while we're not going to spend a lot of time talking about chemo immunotherapy, in 2021, when you're thinking about it in the frontline setting, FCR is best for young fit patients who have TP53 intact, who have IGHV, who are mutated in IGHV. Those patients have the potential for cure, and those are the patients who we would consider for chemo immunotherapy at this time. Well, when you're thinking about chemo immunotherapy, there's more than one potential choice. And I want to highlight the results of the German CLL study group Cll8 Trial, which is a randomized trial of FCR, which I just mentioned from the Cll8 study, as compared to bendamustine rituximab. The headline from this trial was that FCR was superior in terms of progression-free survival to bendamustine rituximab. So in a young, fit patient, really FCR remains the standard of care if chemo immunotherapy is being considered. That PFS advantage was most apparent in patients who are younger than age 65. So one of the conclusions from the chemo immunotherapy section is that for patients who are FCR ideal candidates, bendamustine rituximab is not an ideal substitute. BR may play a limited role in 2020 or 2021 now in older patients who have favorable characteristics, but so many other choices that we need to consider that we'll now delve into in this part of the talk. I next want to highlight another trial conducted by the German CLL study group called Cll11. And this is a randomized controlled trial of obinutuzumab, which is a CD20 antibody in combination with chlorambucil versus chlorambucil as a monotherapy. And you may be saying to yourself, why is he even highlighting this trial? Chlorambucil is a ridiculous control arm. However, this was a positive trial in terms of progression-free survival, favoring the G-chlorambucil over the chlorambucil. And what I want you to recognize is that most of the clinical trials that I'll present for the novel agent-based therapy are now utilizing this as the control. So it's important from a historical perspective. It's also an active agent and a very reasonable comparison. Here I highlight in the trial, this G-chlorambucil is the new chlorambucil in upcoming studies for novel agents. Still an important regimen potentially for patients with favorable characteristics. Now let's start to look at the novel agents, and I'll start by talking about Ibrutinib, which is a BTK inhibitor. It's approved in the US in the frontline and relapse refractory settings, and this is the frontline trial that led to the approval of Ibrutinib. This is called the Resonate-2 trial. It was published in 2015 by Jan Berger, and this is a head-to-head comparison of Ibrutinib versus chlorambucil, one-to-one randomization. Keep in mind, this patient population is an older patient population. Patients were 65 and older, and you could not have a deletion 17p to participate in this trial. You can see from the figures that the progression-free survival was overwhelmingly positive, favoring Ibrutinib over chlorambucil, as was overall survival, making Ibrutinib a standard of care for this particular patient population. I wanted to highlight longer-term follow-up data available from this trial because keep in mind, these are continuous therapies. So not only are we interested in the immediate efficacy, but in terms of tolerability, it's also important whether or not patients can stay on these therapies long-term. I'm thankful to Dr. Berger for having presented this because we can see that the overall discontinuation rate was 41% at 5 years, and that the majority of discontinuations, or the most common reason for discontinuation, was adverse events. About 52% of the discontinuation rates were due to AEs. So it's very important to keep in mind not only the activity, but the adverse event profile of these agents. And then also to highlight a limitation from all of the clinical trials that I'll talk about today is that we have very limited data on next therapies for these patient populations once they discontinue the study drug. Next, I want to focus on some other very important clinical trials that have been recently presented looking at Ibrutinib. This is the Econ 1912 trial, and this is a randomized trial in a generally younger patient population, I believe 70 and younger, of Ibrutinib plus rituximab or FCR. So here we're testing that regimen, which I highlighted in the CLL8 and CLL10 trials versus Ibrutinib rituximab. So it's a very relevant comparison. And the take home from this trial was that the PFS and overall survival were favoring the Ibrutinib arm, which is the red curve on the Kaplan-Meier curves. Very important to note that patients with a deletion 17p could not participate in this trial. And the other thing that's really important to note is that in CLL, not only are we focused on the genetic profile, but also the IGHV status. When we're thinking back to those CLL8 data that I presented earlier, where I said mutated patients should still be potentially receiving chemo immunotherapy, you can see that there was no statistically significant difference for outcomes for FCR versus Ibrutinib rituximab in the IGHV mutated patients, but overwhelmingly positive outcome for Ibrutinib-based therapy in the IGHV unmutated patients. So my take home from this is that FCR is still part of the conversation, at least. It's not mandated for IGHV mutated patients, but there's absolutely no role for chemo immunotherapy if you're IGHV unmutated in 2021, given the choices that we have. I also wanted to highlight the companion trial to the ECOG study, which was a trial conducted by the Alliance Group in the US in an older patient population. And here the randomization was a little bit different. It was a 1-to-1-to-1 randomization of Ibrutinib with or without rituximab versus bendamustine rituximab, with the primary endpoint being progression-free survival for the Ibrutinib-based therapy as compared to BR. And the take-home from this trial were twofold. Number one, the Ibrutinib-based therapy met the primary endpoint. Either Ibrutinib or Ibrutinib with rituximab was better than BR. The second take-home was that rituximab added nothing to Ibrutinib. And you can see the red and blue Kaplan-Meier curves are the Ibrutinib-based therapies. They're superimposable into progression-free survival. So most experts in the field believe that there's probably no role to adding rituximab to Ibrutinib in the frontline setting, certainly not in older patients and probably not in the younger patient population. Next, I want to highlight the Illuminate Trial, which was another Ibrutinib-based regimen, which has recently been tested in the frontline setting. And here the combination is Ibrutinib plus obinutuzumab. But the reason why I included the CLL11 trial earlier was that the obinutuzumab chlorambucil is now the control arm here. And so you can see from this randomized trial that the Ibrutinib-based therapy in the yellowish curve is better than the chlorambucil obinutuzumab. However, the one major limitation of this trial is that there's no Ibrutinib monotherapy as a control arm, so it's incredibly hard to judge whether or not there's an added benefit to obinutuzumab. In my opinion, based on this trial and the Resonate-2 data set, that Ibrutinib monotherapy remains the standard of care, no clear role for adding obinutuzumab in this setting. Next, I want to switch gears to another BTK inhibitor, and this is acalabrutinib, which is a next generation BTK inhibitor, more specific with less off-target effects, which was recently tested and presented and published as part of the Elevate-TN trial. And this is a 3-arm, 1-to-1-to-1 randomization of acala with or without obinutuzumab, as compared to that same control, which is the CLL11 regimen, obinutuzumab plus chlorambucil. And what's really nice about this trial, besides the fact that the acalabrutinib-based therapy was superior to the control arm, was that now we have randomized data for acala with or without we'll call it a next generation CD20 antibody, showing that there was a PFS advantage with relatively short follow-up for acalabrutinib versus acala as a monotherapy. At 24 months, 93% versus 87%. And so the limitation of the Illuminate trial is overcome here in part because we now have that third arm, which does suggest that there may be a PFS advantage. Of course, we'd like to see some longer term follow-up to make sure that that is in fact confirmed. Well, I'd like to also mention a third BTK inhibitor, which is called Zanubrutnib, which is being studied in the Cll8 Trial. And the data that I'd like to present here include patients specifically treated in the treatment-naive setting or frontline setting who had a deletion 17p. And to date, 109 patients have been presented so far from this particular study. What you might have noticed from all of the publications and presentations that I've given so far is that there's an incredibly small number of patients with a deletion 17p who've been studied with either acalabrutinib or ibrutinib in the frontline setting. And so here we have more than 100 patients treated with this poor risk feature with Zanubrutnib, and that's why I included this abstract. You can see the overall response rate is quite impressive at 94.5%, as is the progression-free and overall survival in this patient population who traditionally with chemo immunotherapy have done incredibly poor. Well, now let's totally switch gears to a different class of agents and talk about Venetoclax. This is a BCL2 inhibitor, which is approved in the US in both the frontline in combination with a Venetoclax and the relapse refractory setting in combination with rituximab or as a monotherapy. Venetoclax is somewhat unique from the BTK inhibitors in that the most popular way to administer this drug is to be given in a fixed duration schedule. This is the Cll8 trial, again conducted by the German CLL study group, where the combination of Venetoclax is compared to a similar regimen that I mentioned previously, chlorambucil with obinutuzumab. So again, that CLL11 regimen or CLL11-like regimen is being utilized over and over again as the control arm. And here's another example of a novel agent-based therapy, now a 12-month fixed duration, which was better than that as a control arm. You can see the hazard ratio is 0.31, pretty good follow-up at 39.6 months. And at 36 months, the PFS was 82% for ven-based therapy and only 50% for the chlorambucil obinutuzumab-based therapy. So a positive trial, another important drug added to the toolbox in the frontline setting for patients with CLL. I also wanted to take a look at some outcomes stratified by risk. And here we can see outcomes stratified by MRD status at the end of therapy. Much, much better to be MRD undetectable at a level or sensitivity of 10 to the -4th after 12 months of therapy as compared to those who are positive. So this to me identifies a very important population who are key for future clinical trials. At our center, we have a study where we add therapies to Venetoclax if patients are MRD positive. Outcomes here are stratified by deletion 17p status. So it's, relatively small number of patients in the del 17p arm, but you can see there's a difference. And so whether it's the targeted agent, Venetoclax, or the fact that it's given in a fixed duration schedule suggests to me that there may be room for improvement, either by combination therapies or by extending the schedule of the Venetoclax. And then outcomes here are stratified by IGHV status. And you can see that while patients who have unmutated disease, which is this black curve versus this curve, clearly should be getting the novel agent. So the same theme as what we saw with Ibrutinib. Patients who have IGHV mutated disease, which is this curve and this curve, are more similar and statistically similar. You can still make an argument that for patients who have favorable risk features, whether you give them chemo immunotherapy or a BTK inhibitor or Venetoclax, they all seem to do quite well. Next, I'd like to focus on the newest kid on the block, which is a PI3K inhibitor called umbralisib, which was combined with a CD20 antibody called ublituximab in a trial called Unity CLL. I want to overemphasize that this drug is not yet approved anywhere for the management of patients with CLL, but this is the newest randomized phase 3 trial we have available. And here the comparison again is obinutuzumab with chlorambucil, and I'll editorialize to say that hopefully this is one of the last trials we see with that as a control arm, as clearly our novel agents are better than that at this time. The other thing about this trial is a little bit unique, is that it was a combined patient population, both treatment naive and relapse refractory. More than 600 patients total participated in the trial. The randomization was 1-to-1, and the primary endpoint was progression-free survival. And here you can see the primary endpoint for all comers was superior for the green curve, which is the umbralisib ublituximab, versus the control arm, which is the CLL11. Here you can see the hazard ratios, which are stratified by treatment naive versus relapse refractory, 0.48 and 0.60. It's interesting that we really don't have a lot of data for G-chlorambucil in the relapse refractory setting to know how well this curve performed. And here we have data for overall response rate, which was significantly different, 83.3% versus 68.7%. Of course, with PI3K inhibitors, it's very important to look at the adverse event profile, probably more so than any novel agent. We can see the most common adverse event was diarrhea with the U2 regimen, which is what they are calling it. But then let's focus in on the PI3K specific abnormalities. Any grade liver dysfunction was between 14 and 17%, colitis 4.9%, pneumonitis 2.9%, rash 12.6%, and opportunistic infections were 14.1%. And so the take home from this study was that U2 demonstrated superior PFS as compared to the control. The AE profile was as expected, but potentially somewhat better than other PI3K inhibitors. And this is the first randomized phase 3 trial in treatment-naive CLL to show a benefit, which by itself is a major achievement considering many other PI3K inhibitors were not safe enough to be explored in a randomized setting in the frontline setting for patients with CLL. Well, next I want to talk about novel combinations, and here we'll evaluate the Captivate trial, which is the combination of Ibrutinib with Venetoclax in the frontline setting. This is a really interesting and complicated study design, and so all patients get the combination of Ibrutinib with Venetoclax. There's a lead-in for Ibrutinib for 3 cycles, followed by 12 additional cycles of the combination of I plus V, and then there's this complicated randomization based on MRD status. If you're MRD undetectable, you're randomized to placebo or Ibrutinib. If you're MRD detectable, you're randomized to Ibrutinib versus Ibrutinib plus Venetoclax. And then the primary endpoint was 1-year disease-free survival, which many people have argued is probably too soon to really understand the potential benefits of these individual strategies. Here you can see how things were broken down. Most patients, 86 patients, were able to achieve MRD undetectable disease, 63 were not. And then this is the disease-free survival for patients who are confirmed MRD undetectable. No difference between these curves, which many have argued is a rationale for stopping the placebo as compared to continued Ibrutinib therapy. Although I'd like another year to go by to see if these curves truly are the same or not. And then this is the UMRD rates for patients who went on to Ibrutinib monotherapy versus Ibrutinib plus Venetoclax continued therapy. And it does seem responses are deepening when you are receiving long-term combination therapy versus Ibrutinib as a monotherapy. Incredibly complicated slide that was presented looking at adverse events for these combinations. The take home was that, first of all, there didn't seem to be any surprises here. You saw some BTK inhibitor associated toxicities like atrial fibrillation at relatively low rates, and very few long-term AEs associated with this particular strategy. So the take home from this trial was that the 30-month PFS rates across all arms compared favorably to potential other frontline fixed duration regimens. I think that's a little bit of a stretch. AEs decreased after the first 6 months of the combination, no new safety signals. And this is an oral chemotherapy-free combination, which does seem to be able to achieve a deep remission. Of course, there is a randomized trial that is ongoing or has not yet been reported, looking at the combination of I plus V as compared to the CLL11 regimen again. So we'll wait for those results, but I think few people expect the CLL11 regimen to be better, given the fact that both Ibrutinib and Venetoclax have already demonstrated individually to be superior to that combination. So I'll highlight what are some of the gaps as people in the audience are thinking about what trials to design next. In my opinion, it's not clear that IGHV mutated patients absolutely require novel agent-based therapy in the frontline setting. With that being said, it's completely reasonable, and no patient is mandated to receive chemo immunotherapy in 2021. While Ibrutinib is superior to chemo immunotherapy, and Ven-Obin or Acala-Obin is superior to G-chlorambucil, we have no direct comparisons between Ibrutinib, Acalabrutinib, and Venetoclax in the frontline setting, or at this time in the relapse refractory setting. And so we're forced to live in a world where we have no ability to select which modern novel agent is most appropriate for patients. And then current studies speak to the importance of selecting clinically relevant controls. In the next studies, hopefully no one is designing a randomized trial today with G-chlorambucil as the control arm. And then several studies remain to read out with that control arm or chemo immunotherapy, and I think they have limited value. Now I'll switch gears to the relapse refractory setting and just summarize where we left off. So we have four main options for chemotherapy-free pathways in the frontline setting, and I've talked about these already extensively. These are the approved agents in the US, or the approved combinations in the US. And in the relapse refractory setting, we have 5 targeted agents approved. And those include Ibrutinib, Acalabrutinib, Idelalisib, and Duvelisib, which are PI3K inhibitors, as well as Venetoclax. And so we have multiple choices, and you can start to see that in a world where most patients are receiving novel agent-based therapies, we have so many combinations to consider. Doing simple math, more than 120 potential sequences. And so we really need to try to not only evaluate the data in the relapse refractory setting in isolation, but also how patients fit on individual pathways and how we can sequence these novel agents, which none of which are given with curative intent at this time. And just to overemphasize this point, I'll mention that patients on all of the relapse refractory trials, essentially all patients, were not treated on chemotherapy-free pathways or with prior novel agents. And so if you look at nearly 1,000 patients treated in the relapse refractory setting, and I've mentioned all the trials here in the table, only 9 patients in total from 6 studies were previously treated with at least one BTK inhibitor, PI3K inhibitor, or Venetoclax, and likely none with a modern chemotherapy-free pathway. So we're kind of stuck in this data-free zone. Where in the relapse refractory setting, we're expecting to see all of these patients who either started on Ibrutinib or Acalabrutinib or Venetoclax, and yet we have no data to guide what should be the most appropriate therapy after they come off of one of those agents. And so what I would argue is that we should try to recognize first and foremost that the data are imperfect, but then try to organize the task for how to sequence therapies. And of course, the first thing is to select what's the best frontline therapy. And I've given you all the data that exists. And we just need to recognize that there's no prospective comparative trial for the 2 key classes, which will include BTK inhibitors and Venetoclax. There are trials that are being conducted or designed that might be helpful, but certainly not for today's discussion. The second step is upon relapse or progression, there are 3 big considerations in selecting how to manage patients in the relapse refractory setting from 2 distinct patient groups. And those groups are either patients who got a BTK inhibitor to begin with, or patients who got Venetoclax to begin with. And then those considerations include the reasons for discontinuation. So why did you come off your first therapy? Was it because you finished the therapy appropriately, like Venetoclax? Did you have progression of disease with some known or unknown resistance mechanism, or were you intolerant to the agent? And all of these are really realistic things that can happen. Second consideration is available options. I'm talking to you as if you're sitting in the US with me and you have the same choices, but obviously in individual countries, the levels of approval and the availability from a payer perspective are different. And so that needs to be considered. And I'm really happy that that's going to be done at this conference, because many of the things I say may not necessarily be relevant to the audience. And so you need to think about how you would shape this conversation based on what options you have available. And then consideration of the levels of evidence. Are we talking about prospective, interventional studies, randomized studies to support a decision? Is it a registry that's prospective, or are these chart reviews or real-world data sets? And so that's kind of where we are, and think about that think about that when interpreting any of the data that I'm mentioning. I'll try to be really direct and summarize what exists. And so in the relapse refractory setting, first patient that we might encounter is a patient who's novel agent naive, meaning this is the patient who got FCR or BR years ago. they're relapsing, and now you need to decide what to give them. And the choices exist, at least here in the US, include BTK inhibitors, PI3K inhibitors, or Venetoclax as the first novel agent. And just to summarize everything, my opinion is that in all circumstances, when clinically acceptable, if you're thinking about which novel agent to give, think about giving a BTK inhibitor or Venetoclax before any of the approved PI3K inhibitors. So it should be BTK or Ven before PI3K, and there's no definitive comparative data to support whether you should give Venetoclax or a BTK inhibitor as the first novel agent, but there's some limited data that's intriguing. Here I wanted to put a side-by-side comparison of what we call real-world data versus a clinical trial. And this analysis, which was performed by our group in partnership with many people from around the US, looked at 683 patients who were treated in the relapse refractory setting with either Ibrutinib or Idelalisib as their first novel agent. And here you can see our head-to-head comparison in the relapse refractory setting of Ibrutinib versus Idela. Clearly, Ibrutinib is better. Many times, experts will look at these data with many limitations and be somewhat skeptical. So they did do a clinical Ibrutinib versus BR or Idelalisib rituximab, and this is the Ascend trial, which was a randomized trial in the relapse refractory setting, which clearly showed that Acala was better than Idela rituximab, almost completely mimicking the results we found 3 years earlier. Here we'll think about BTK inhibitors versus Venetoclax rituximab as the first novel agent in the relapse refractory setting. I've included the key trials to consider, including the Resonate trial, which looked at Ibrutinib versus ofatumumab, the Murano trial, which looked at Ven rituximab versus bendamustine rituximab, and the Ascend trial, which I already previously mentioned on the last slide. I'm not going to have an answer for you, except to say that there are things that one can consider in terms of pluses and minuses. In favor of the BTK inhibitors in this setting, they're convenient. There's no infusions or TLS monitoring. We have more long-term data for them than anything else. We have prospective data for the efficacy of Venetoclax at the time of progression from Ibrutinib. And there are several randomized trials with overall survival benefit in the frontline and relapse refractory setting. In favor of Venetoclax, it's time limited. Many patients want to stop, and so Ven or the Murano regimen can be given for 2 years and then stop. There's no unique toxicities associated with Ven that need to be highlighted, except and including no cardiac or bleeding risks. Venetoclax is generally well tolerated. There's a TLS risk, which I'll mention, and there's some mild GI and hematologic toxicities, but no autoimmune or immune-mediated phenomena to consider or cardiac events. There's less concern for long-term adherence. You give 2 years worth of therapy and you stop for everybody, so at 2 years, everybody should be off drug. And there's potential for cost savings if therapy is durable in the setting of a time-limited regimen. These are data presented by Toby Iyer and our group, where he looked at, in novel agent naive treated patients, Ibrutinib as compared to Ven with or without an anti-CD20, somewhat comparable patient population. Here I'm highlighting the overall survival, which there was no difference. If you reference the paper, progression-free survival in this comparison did appear to favor the Venetoclax-based therapy. So an intriguing result, unfortunately, no randomized trial being conducted to help support that the decision of one over the other. Now we'll finally get to the point where we're able to talk about patients who started with a novel agent. And here we'll break it down into these pathways. We'll start with people who either got Ibrutinib or Acalabrutinib as their first therapy. Keep in mind that all BTK inhibitors are given as continuous therapies right now. You treat to progression, transformation, or adverse event. And I've just jumped back to the data again from Jan Berger from Resonate 2. This is the frontline data, emphasizing again and again, 41% discontinuation rate at 5 years. So for almost half the patients within 5 years, you're going to need to make a decision about potentially a next therapy. Now we'll talk about first novel agent in the relapse refractory setting when you started with a BTK inhibitor, and there's a growing list of options. They include an alternate BTK inhibitor, so going from Ibrutinib to Acala, Acala to Ibrutinib, going to a BCL2 inhibitor like Venetoclax, either monotherapy or with rituximab, or a PI3K inhibitor, Idela or Duvelisib. Apologies with some of the language on these slides. The conversion wasn't perfect, but I think you get the point. There are three major considerations to think about when you're going from BTK to next novel agent. That includes the reason for BTK inhibitor discontinuation, either adverse event or progression of disease, the available options, and then again, the levels of evidence. So if you were intolerant to the BTK inhibitor, your choices are either to go with an alternate BTK inhibitor, a PI3K inhibitor, or Venetoclax-based therapy. If you are resistant to a BTK inhibitor, there's no role for switching to an alternate covalent BTK inhibitor. Think about Venetoclax, a PI3K inhibitor, or think about clinical trials. Here I've again shown two real-world studies that we presented as a group to help guide decision-making. This is a trial where we looked specifically at Ibrutinib failures and tried to stratify outcomes by looking at either Venetoclax or a PI3K inhibitor, idelalisib. If you're an Ibrutinib progressor, you should go with Venetoclax based on this analysis. Then we tried to nuance things a little bit more and look at patients who came off of Ibrutinib and stratified outcomes by the reason for discontinuation. If you discontinue due to an adverse event, it's very reasonable to think about an alternate kinase inhibitor where the median PFS was not reached, from going from Ibrutinib to idelalisib, for example, whereas it didn't seem to be very beneficial to go from Ibrutinib to idelalisib in the setting of BTK inhibitor resistance. Well, let's talk about what prospective data exists for using an alternate kinase inhibitor. These are data presented by my friend Kerry Rogers looking at acalabrutinib after Ibrutinib in the setting of Ibrutinib intolerance. Therefore, this is a relapse refractory trial. The take home here was that we saw excellent progression-free survival for acala in this setting. At a median follow-up of 23 months, 62% of patients remained on acala. And also very important, in a patient population, all of whom discontinued due to adverse event, discontinued Ibrutinib due to adverse event, the DC rate for acala was only 12%. We conducted a similar trial with umbralisib, the PI3K inhibitor, following either Ibrutinib or idelalisib discontinuation due to adverse event. This paper is being published in Blood. I think it's online at this time. The estimated median PFS for Umbro was 23.5 months. The discontinuation rate due to adverse event, very similar to what Dr. Rogers found, was 12%. Now let's delve into the world of BCL2 inhibitors after BTK inhibitors. And I'm starting with the Murano trial, which was Ven-R as compared to bendamustine rituximab. And I want to just highlight that while this trial was overwhelmingly positive, favoring VR over BR, there were absolutely or very few patients on this trial who actually started with a BTK inhibitor. And so this is essentially a novel agent, naive patient population. While the trial is positive, we have no data to yet support whether or not we would see the same PFS in patients who had seen a previous BTK inhibitor. This regimen is impressive by the fact that it has induced deep remissions. And what we saw at the ASH meeting, which I found to be particularly interesting, was that, keep in mind, everybody gets 24 months worth of therapy, they stop. We then looked at, the investigators then looked at the time from end of therapy to when you go from MRD undetectable to detectable. That median was 19.4 months. They then looked at the time from MRD conversion, which is undetectable to detectable, to actual progression of disease, and that time was 25.2 months. So this gives us a nice window into the kinetics of relapse when we're first looking at MRD undetectable disease at the end of discontinuation, to MRD detection, to then clinical progression. There was no new safety signals associated with this regimen. And the conclusion here was that Ven-R displayed a durable response, a PFS and overall survival benefit over BR, MRD doubling rates accelerated by poor baseline characteristics. I didn't mention those, but those included del17P, IGHV unmutated status, and that MRD status at the end of therapy predicted for outcomes. Well, while that trial did not include patients who received a prior BTK inhibitor, there have been trials that have looked at that question, and this is data presented by Jeff Jones a little bit earlier, for Ven monotherapy after either Ibrutinib or idelalisib. And this is an interesting study in that this is the only prospective data showing Venetoclax activity in a BTK inhibitor resistant patient population. Some patients were BTK inhibitor intolerant, but more were BTK inhibitor resistant. You can see the PFS there. Median PFS was approximately 2 years. And this agent, therefore, is an FDA-approved agent for use in this particular patient population. Almost identical results were seen for Venetoclax after idelalisib discontinuation. Well, now let's switch gears and start with a pathway where patients are receiving Venetoclax-based therapy. In the US, the only option there would be Venetoclax given for a total of 12 months and then discontinuation. It's a time-limited therapy. The strategy is treat to completion of therapy, CLL progression, transformation, or adverse event. And just like the Ibrutinib case or the BTK inhibitor case, when you start with Venetoclax in the frontline setting, you have several options to consider. Interesting, one of them is just going back to Venetoclax again. We call this Ven retreatment, or going to a covalent BTK inhibitor, or going to a PI3K inhibitor. And the major considerations there to consider include the reasons for discontinuation, and I mentioned those already, the available options, and again, the levels of evidence to support the decision. Here I'm highlighting two ASH abstracts, which looked at patients who got a Venetoclax-based regimen, largely in the relapse refractory setting, and then went on to receive another Venetoclax-based regimen at the time of progression. So this is Ven retreatment. Extremely limited data sets, very small numbers of patients, but we can see even in these early progressors, the best overall response rate to Ven retreatment here was 72.2%. Here, a data set that our group under Dr. Megan Thompson presented, multi-center analysis, again, found the overall response rate for Ven retreatment was 72.2%. So I'll just flip back to that slide. It's almost, it's very impressive to me that two independent groups could study the exact same question retrospectively and come up with the exact same overall response rate. So that's probably what it is in these early progressors after Ven-based therapy. Next, I want to focus on patients who were BTK inhibitor naive, who started with a Venetoclax-based regimen and then progressed, and what the data are for using a BTK inhibitor in that setting. Seems like common sense, but there are really no prospective data sets available. We published this data set in CCR a couple of years ago looking at BTK inhibitor use, largely Ibrutinib post-Venetoclax, and found an overall response rate of 84%, a median PFS of 32 months, and a median follow-up of 10.5 months. So very reasonable strategy in BTK inhibitor naive patients. The Australian group looked at a smaller number, published it in Blood, and found nearly identical results with a median progression-free survival of 34 months. Think about patients who have been BTK inhibitor exposed. So this is a patient population where patients received a BTK inhibitor, got Venetoclax, and then went on to a BTK inhibitor. And here the reason for discontinuation is really important. You can see for patients who were previously BTK inhibitor intolerant, switching to an alternate BTK inhibitor resulted in a durable response with a overall response rate of 70%. But if you started with a drug like Ibrutinib and you were resistant, went on to Venetoclax, and then went on to receive Acalabrutinib, the median PFS was 4 months, so probably not the best strategy. And similarly, in patients who had received a prior BTK inhibitor, then got Venetoclax, and then went on to a PI3K inhibitor, the median PFS was only 4 months, to me suggesting that there's probably tremendous overlap in reasons or mechanisms of resistance between BTK inhibitors and PI3K inhibitors to account for this finding. So now let's focus on the future. What's beyond the current pathway? And I wanted to start to talk about the class of non-covalent BTK inhibitors, none of which are approved, but I had recently presented data on LOXO-305 at the most recent ASH meeting. And LOXO-305 is a non-covalent BTK inhibitor, which tries to address several problems, which I've already highlighted. Here you see that Ibrutinib discontinuation is just one example from 4 prospective trials, range between 41 and 54%, with the most common reasons being either adverse event or progression of disease secondary to resistance. So these are real clinical dilemmas that need to be faced. And here you can see that probably half of at least half of the discontinuation events in the setting of progression are due to BTK mutations, limiting the binding ability of covalent BTK inhibitors. And so non-covalent BTK inhibitors have the potential to overcome that. And LOXO-305 is one of those agents. This is a large phase 1/2 trial. It's called the Bruin study, which included patients with lymphoma and CLL, 3+3 design. 170 patients with CLL were included in the analysis for safety, and 139 patients were included in the analysis for efficacy. Here you can see the entire patient population. Median number of prior therapies was 3, but if they happen to have received a prior BTK inhibitor, the median number of therapies was actually 4. Most patients had received what you would expect, including 86% had a prior BTK inhibitor. Some patients had CAR T, allotransplant, PI3K inhibitors, and Venetoclax. So a pretty heavily pretreated patient population, all of whom received standard therapies. And so to me, this suggests it's a real world population. These are the patients I'm literally seeing in my clinic every day. Here we have baseline molecular characteristics, including the proportion of patients with a CYS481 mutant disease, as well as other high-risk features like DEL17P, TP53 mutation, IGHV mutational status. I think with a phase 1 trial, it's always most relevant to start off by talking about safety. This is the all-grade treatment emergent adverse events at 10% or more. The take home for myself and I think all investigators here was that this was a very well-tolerated drug. When you look at the discontinuation rate due to adverse events, only 5 of 323 patients, 1.5%, discontinued due to an adverse event. And therefore, the dose of 200 milligrams daily was selected as the recommended phase 2 dose. But just to dig into this a little bit more, I think it's important to look at BTK inhibitor-associated toxicities like arthralgias, any grade 5%, atrial fib or flutter, less than 1%, major bleeding, major hemorrhage, less than 1%. I think the waterfall plot speaks for itself. Almost all patients had a deep response in terms of maximal change in lymph nodes. The blue bars indicate patients who had a prior BTK inhibitor and discontinued either due to progression or toxicity. And then the red hash marks are prior BCL2 inhibitors, and the stars are CYS481 mutant disease. And you can see across the board that there was activity. Here we see the overall response rate was 63%, which was maintained at 62% in BTK inhibitor pretreated patients. And then for the subset of patients who have longer term follow-up, we start with that 63%, but if you have patients with 6 or more months follow-up, 8 or more months, or 10 or more months, it goes to 68, 71, and 86%. So deepening responses over time. Here, the swimmer's plot speaks for itself. Median follow-up here is only 6 months, but you can see that most patients have ongoing with this drug, and that at this time point, 94% of responding patients are ongoing and in response. There are only 5 responding patients who discontinued, 4 for progression of disease, 1 patient electively to undergo a stem cell transplant. To be completely balanced, I do want to mention that there are other non-covalent BTK inhibitors that are being studied. This is a molecule called ARC-531 presented by Jennifer Woyak. Small number of patients here in this particular study, but what you can see was that the drug was active, and you can see here the waterfall plot. No CRs, all PRs, and then 8 of 9 patients with CYS481 mutant disease at a dose of 65 milligrams achieved at least a PR, so another agent to consider. Next, I'll delve into the world of cellular therapies, and this is a summary table put together by Matthew Davis looking at all of the previous trials looking at CAR T directed against CD19. And here we can see a very mixed patient population, very small numbers of patients, mixed results in terms of the overall response rate and CR rate. There have been a couple of trials that were presented at the ASH meeting looking at the lysocaptogene agent presented by Tanya Siddiqui and Bill Weirda. This is a patient population that I think is very interested, a high risk, all Ibrutinib treated patient population, many of whom had also seen Venetoclax, 22 patients. So another small trial, which did show some promising activity here for this particular agent. Overall response rate was 82%, 68% CRs, median PFS was 13 months, and duration of response was 50% at 12 months. The product did seem to be relatively well tolerated. One concern for me is that most of the progressors from this data set were progressing with Richter's transformation. So certainly an active agent in a modern patient population. Still many raise the question whether or not these agents could be moved to an earlier line of therapy for an improved outcome. Bill Weirda looked at the same product in combination with Ibrutinib in a relapse refractory patient population. Everybody had seen prior Ibrutinib, but here the goal of the Ibrutinib was not to treat the CLL, but to potentially improve the activity of the T cells themselves. Ibrutinib has multiple off-target effects, including ITK. Here you can see the summary from this data set was that the Lysocell plus Ibrutinib was well tolerated, low rates of CRS or neurotoxicity. The same was true for the previous study. The response rate was high at 95%. 63% CRs, and a high proportion of patients with MRD negativity. I advise everybody not to compare trials, different patient populations. Very hard to judge whether or not CAR T requires Ibrutinib or a BTK inhibitor, but certainly an intriguing result. And then finally, I'll mention data presented last year at ASH by my colleague Lindsay Roker from MSK, where she started to ask the question, what, if any, is the role for allogeneic stem cell transplantation in patients who are treated with novel agents? Certainly, the pendulum may at one point had swung away from allo transplant, given the success we saw with Ibrutinib, Venetoclax, and other agents. But as we cycle through the pathway where patients are on multiple agents, they may get to the point where they require a cellular therapy. So Lindsay put together a multi-center analysis. 24-month PFS was 63% for allo transplant. There didn't seem to be a difference whether patients had one novel agent or two or more novel agents. So to me, suggests that you can go from Ibrutinib to Venetoclax and then make the decision. And it didn't appear to show a difference when PFS was stratified by novel agent most immediate prior to allo transplant, including Ibrutinib or Venetoclax. So the number of novel agents and the specific novel agent used prior to transplant didn't impact survival outcomes. So I'll end the talk by just reminding everybody what I talked about. On the pathway that starts with a BTK inhibitor, we think about reasons for discontinuation when we're thinking about treatment in the relapse refractory setting. In the setting of progression, Venetoclax is the obvious choice, followed by either clinical trial, PI3K inhibitor, or cellular therapy. In the setting of intolerance, we have two options. First of all, wait for progression of disease for CLL, but then think about an alternate kinase inhibitor like Acalabrutinib or umbralisib if it's ever approved, or go to a BCL2 inhibitor like Venetoclax, rituximab, or Venetoclax monotherapy, and then switch at the time of progression. And then finally, think about PI3K inhibitors, cellular therapies, or clinical trials. On the pathway that starts with Venetoclax Obin, you have three choices. If they progress and they're BTK inhibitor naive, go to a BTK inhibitor. If they are progressing after the completion of therapy, two choices to think about. Think about retreatment with Venetoclax, and if that doesn't work, a BTK inhibitor, or a BTK inhibitor, and if that doesn't work, Venetoclax. Or if they're intolerant to Venetoclax, well, think about retreatment again with better supportive care, or when they progress, a BTK inhibitor, and then the opposite sequence. I want to thank you for attending my lecture. Huge honor to be presenting at this international conference, and I look forward to future collaborations. Thank you so much.